case about 67 years female with no known comorbidities. She was diagnosed with carcinoma right breast in February 2018. Upfront, she underwent modified radical mastectomy with axillary clearance on 25th March 2018. After the operation, the histopathology report came something like this: invasive ductal carcinoma grade 2, all margins were clear, LVSI present. Pathologically, it was T2, N3A, MX. There was a huge nodal burden, 25 lymph nodes were positive out of 26 removed. Her ERPR status was negative, her HER2 status was positive. So she was planned accordingly. She received 4 cycles of AC, doxorubicin cyclophosphamide, followed by 4 cycles of docetaxel plus trastuzumab, and she continued to receive trastuzumab for 1 year, almost 17 cycles. She completed her maintenance trastuzumab in March 2019. In the meantime, she received chest wall radiotherapy to chest wall and supraclavicular region in November 2018, as there was a huge nodal burden. We considered to give RT to chest wall and supraclav. She was doing well after completion of the maintenance Herceptin. At the end of 2019, she complains of headache and some CNS symptoms. So we have done an MRI brain at that time. And MRI showed a single lesion in the right frontal region, which is around 2.5 centimeter in size. And MRI revealed there is no lesion in the other parts of the brain. So this was a single metastasis. At that time, we have done a PET CT scan. It showed no disease in the bones, liver, or anywhere. There was a suspicious lung nodule in the right side, but HCD max was equivocal, like 3. There was a suspicious right axillary node, but we have done a FNAC and it came negative for any malignant cell. As it was a single lesion, so the plan was to give stereotactic radiosurgery. So patient received 27 gray in 3 fractions between 23rd November 2019 to 26th November 2019. She received 3 fractions of RT27 gray to that particular area of the brain. After completion of the radiotherapy, she was started with lapatinib and capecitabine and continued it for 6 months. She was tolerating the chemo very well and doing well also. At the end of the lapatinib, maybe in July, she started to develop some nodule in her above the sternal area. This area, she developed a chest wall nodule. And we have done a biopsy from this area. And that biopsy revealed same like before, ERPR negative, HER2 positive. As we have previously given trastuzumab to this patient for 1 year, we have decided to give TDM1 Khodeza to this patient for 6 months. So she received 6 cycles of TDM1. Initially, there was good response. These nodules were decreasing in size, but at the end of 5th cycle, this nodule started to grow back. So in the January 2021, her chest wall became like this. The place where we have done the biopsy, there again a big chest nodule has developed, and throughout the right side, this is our operated side, and also it has extended to left side as well. So again, we have done a biopsy from that side, and this time it came as metastatic ductal carcinoma, CNBC. At the same time, we have done IHC-based PD-L1 testing. PD-L1 came as negative. So we thought of giving nab-paclitaxel and carboplatin together, 6 cycles, and see the response. And we got a very good response with nab-paclitaxel and carboplatin. The chest wall here, the big nodules, which completely disappeared after giving nab-paclitaxel and carboplatin for 6 cycles. It was a very good response. Unfortunately, patient again developed some CNS symptom in this month, July 2021, and we have done an MRI of the brain, and that MRI shows this time a multiple lesion in the both side of the brain. Here, one lesion, so multiple lesions. Because of the CNS symptom, we have decided to go for a whole brain radiotherapy this time. So it was 30 gray in 10 fractions, Patient tolerated radiotherapy well, and with steroid and radiotherapy, his CNS symptom improved. We have sent a liquid biopsy for this patient, and the liquid biopsy result comes something like this. Tumor mutation burden was 1, microsatellite instability not detected. There was a genomic finding, HRAS present, and also there is a mutation in TP63 gene. So in this current situation, what should be the next treatment option for this particular patient? Thank you all.
I would like to ask the first opinion from Professor Vanderbilt, sir. Sir, please comment regarding this case.
So this is a very unfortunate case. Again, I would probably, if available, also try to check BRCA status, because that could open up therapies for PARP inhibitors, even though you have a liquid biopsy. And most of the time, these liquid biopsies will pick up germline BRCA1 and 2 alterations. They are not germline tests, so they won't pick up complex, large deletions and rearrangements that can occur in the germline. And so for that reason, our genetic counselors have always, and geneticists have always reminded us of the fact that using a liquid biopsy or a tumor-only tissue biopsy is not a substitute for a heritable BRCA1, BRCA2 germline test. Again, it would be very unlikely, but not impossible, that if it didn't pop up on the liquid biopsy, that you could still have a germline alteration. But I have seen it, so it's something to consider, because it would open up therapies for PARP inhibitors, which also may, there is some controversy of how much the PARP inhibitors can actually have blood-brain barrier penetration, but there is some evidence that some of them might. So I think that that's something to consider and think about. The targeted therapies, there really aren't any for the alterations that she has. And one of the things that I also want to point out for liquid biopsies, one cannot really test the blood tumor mutation burden or the microsatellite status. If it's positive, then it's probably likely to be real, but a negative result on a liquid biopsy, for a lot of technical reasons I won't get into, is not truly negative in my view. It's really indeterminate, because it's just, you don't have enough DNA from the cancer cells to really make that assessment with accuracy if it's negative. But the HRAS and the TP53 currently are not really what we would consider druggable targets. That could change. I think many of us know that the KRAS G12C inhibitors have shown a lot of promise, and so there are subsequent newer drugs on the horizon. But for right now, I don't believe that this is a patient that could benefit from anything on the liquid biopsy, unfortunately. In terms of subsequent therapies, again, I don't know what's available to you there, but certainly if this was a HER2 positive disease still, and again, we don't know, the last biopsy we have is that it's triple negative. And so I think the likelihood that this is a heterogeneous tumor is quite high. But if it was still HER2 positive, we would have potential options of using Enhertu, which is a new antibody drug conjugate, which has been approved here and shown efficacy in patients who have even progressed on TDM1. So this is a molecule like TDM1, where it has trastuzumab as the antibody, but then deruxtecan as the chemotherapy part of the antibody drug conjugate. And that really has shown remarkable results. So much to the fact that a lot of us think that as long as there's some HER2 expression, so it doesn't have to be 3+, but could be 1+ or 2+, that there could be efficacy, and that's being tested in various trials right now. So again, I don't know if that's an option for this patient in terms of obtaining that drug, but it would be something that might help both populations of her breast cancer cells, the triple negative and the HER2 positive. And if the thought is that she still has HER2 positive disease in her brain, tucatinib may also be an option if that's available, because that is approved even in treated brain mets as well as untreated brain mets for the trials that were published. I think in light of all of that, if one really feels like, and I kind of am leaning towards this, that this is more still a triple negative breast cancer that has come back after treatment with HER2 positive agents, that, again, I don't know if this is available, but sacituzumab govitecan is approved. This is for triple negative breast cancers in this country. This is another antibody drug conjugate. And TROP2 expression is very common in most epithelial cell malignancies, but the first kind of indication in this country of the study has been in triple negative breast cancer, and common enough that it doesn't seem like measuring TROP2 for the surface protein on these cancers is necessary. And so unlike HER2, where we have to have some sort of predictive diagnostic marker to call it HER2, any triple negative breast cancer really can in this country get, any patient can get this drug. So beyond that, I think the chemotherapy options really are the only other options. She's PD-L1 negative, atezo, and nab-paclitaxel is approved for first line in this country, but I'll be honest, I don't think it's that effective, and has obviously some which can be actually life-threatening. So I think if those options are available to her, that's how I would approach this. But I don't know exactly what testing is available and what drugs are available.
I have two things to add. First of all, the BRCA result we haven't got in hand, but from the lab, what we came to know is it's negative. So there is no BRCA mutation. And the other thing is the chest nodule. This picture is 1 month back, chest wall. This area, again, we are having nodules again. Very small, but still it's progressing. And these are biopsies possible from the new lesion. Same site, again, nodules are coming. So should we do another biopsy or should we try for any chemotherapy? Because chest wall is progressing again.
Yeah, I think getting a superficial biopsy is relatively easy. And I think if you have that opportunity to also, just check the receptor status again, because the next steps really also depend on what drugs are available. Because right now I would be thinking about Enhertu, which is the trastuzumab deruxtecan versus the sacituzumab in terms of antibody drug conjugates. I think either of those, if she can get them, would be very effective if she has HER2 positive disease versus triple negative breast cancer. So I personally would like to know what we're dealing with if she's getting systemic recurrence on the chest wall again. Is this HER2 positive disease or is it triple negative breast cancer again? And that might lean me towards doing one or the other. Now, at the same time, if you don't have any of those as options, or if you only have one or the other, then I'm not sure if there'd be much utility in actually getting the biopsy right now.
I'd like to ask a question to to comment on the case, and as well as I would, Rajesh sir, can you please emphasis on the brain mets management regarding this case, as we see that there is initial oligomets and she underwent SRS and she had a good quality of life. And do you emphasize about this regards?
Yeah. Thank you, Arunangshu. Arunangshu and Shajal. This patient is 67 years old. That's what I came to know. Maybe now she would be near about 70 plus. And only one thing what I would have done upfront was like, if this patient required neoadjuvant, that would have been one. Instead of going for upfront surgery, that's one thing. And the second thing is, I'm not sure whether axilla was treated in the first time because it had 25 nodes positive. But I remember Arunangshu saying chest wall and supraclav alone was treated. If there was some indication to treat the axilla, that would have been good. That's one thing. And the lesion had behaved like a HER2 positive tumor only because the patient has had first developed brain mets and then started to develop chest wall nodules. From the thing, if you see from 2019 was the first time when she had brain mets, and she had lived post radial surgery for 2 years and the disease was under control. I'm not sure whether there was any follow-up imaging in the meantime which showed the brain was normal. That is one thing. I think it should have been done because she had PET scans and multiple evaluation done for each line of chemo in between. As Dr. Ben said, it's good that if you have one biopsy from the skin lesion now. So that would give you whether the patient is currently having TNBC-like picture or whether it's a HER2 positive picture. That's one thing. And another thing is, since the patient has developed now multiple brain mets, one option is whole brain radiation as it's being planned. And I would consider, if possible, we can do whole brain RT now with hippocampal avoidance. That is one option which you can keep in mind. We can do like you can contour the hippocampus and give a margin of 1 centimeter around it and make it as a hippocampal avoidance region, and do IMRT, and you can treat all the lesions. one thing you need to remember is the place where you have given the radiation earlier, 27 grain 3 fractions. Maybe that region you might need to underdose a bit. Otherwise, the patient would have a lot of radiation necrosis. That is one thing you have to keep in mind while planning for radiation now. And if you're not planning for VMAT with hippocampal avoidance or something, so then when you do whole brain RT, maybe better to use a fractionation of 2.5 gray. So that is maybe 32, maybe instead of 3 gray per fraction, you can use a fractionation of 2.5 gray, because this patient has already received 27 grain 3 fractions to the frontal lobe. That is one thing which I would keep in mind. And one more option is, because if the skin nodules are multiple, you can try re-radiation with electrons rather than photons. Electron therapy would be an option for the chest wall. So these are the things which came in mind when I was going through these cases.
All right. So one more question from these cases, as but electron therapy, what is your what do you think? Is it a very difficult situation for us to treat with electron? As you were here.
Shajal, I didn't get your question.
The electron therapy for local recurrence, should we? Is it not that much? We can easily achieve the dose. As Arunangshu, this case was combinedly treated by Kamjan sir and Arunangshu for a long time. And initially, when it was recurrence, and we select for the electron therapy as well. But when it comes TNBC, we go for the chemotherapy. And Arunangshu did a very well look after of this case. So that's why I'm asking, when the case with chest wall recurrence, should we have a good option for the electron therapy? And it's not challenging. This is I want to know from you.
So basically, when there is only a chest wall recurrence, what we do is you try to excise the nodule and then give RT immediately. So that is one option. I mean, it is solitary chest wall nodule. But if you see, when this patient developed chest wall nodule, patient already had brain mets. So it is not like isolated chest wall recurrence where you do like a surgery followed by RT immediately. But this patient had brain mets to start with, and after that the patient developed the chest wall nodule. So whatever plan you have done is correct. Maybe at some point of time try to add electron therapy also to the chest wall to prevent it from further worsening. Maybe that will give her a good quality of life. That is one thing.
And I would like to ask some comments regarding this case again to Professor Dr. Khodeza Madam. Madam, this is also an interesting case, and what do you think about the heterogeneity and the other issues of this case?
Yes, this is another interesting case, and it was initially the case was, I think it was ERPR negative and HER2 positive, and I wonder if there is a scope of doing PDL1 in the beginning of the treatment, because HER2 neo positive and ERPR hormone receptor negative cases, there is chance of being PDL1 positivity. And also at this moment, as we can see that there is a tumor heterogeneity, and now we get, it is a triple negative case. And then presently she is having another skin nodule. And as Dr. Ben has said, as it is superficial, we can go for a biopsy. A re-biopsy, and then we can, there is no other option left. So this is the only, I think, option for doing a biopsy and then go for the hormone receptor and HER2 neo status. And then if we find HER2 positivity, then there will be some scope for treatment or giving better. And then there are other options also, radiotherapy and all those things that you know better than me. So that is the case. And at this moment, no other, as we know, BRCA also negative. The BRCA testing is also came out negative. So this is the only thing we can do. We can do a biopsy. Yes.
Salim sir, do you want to add any further comments regarding the second case? Salim Reza sir.
So we should do the re-biopsy from the chest wall. Then according to the report, then we'll go for the next management. And according to the comment of our Professor Rajesh Balakrishnan, we should go for the electrotherapy of chest wall. And definitely the patient should receive the radiotherapy in the brain for the brain metastasis, but we should think the doses of the radiotherapy. Already Professor Rajesh mentioned 2.5 day per fractions. So this is okay. And as it is BRCA1 and BRCA2 negative, so we should not offer the patient for the olaparib. So, and the patient should be managed as a palliative management. Thank you, Dr. Shajal and Dr. Arunangshu.
Thank you, sir. Professor Manzur, sir.
Thank you so much for a very interesting case. And in this clinical situation, the patient having chest wall recurrence second time. So though it is not becoming an ulceration, if she developed ulceration, that will be the great sufferings. The skin metastasis is visible, so the patient will gradually become very much sick. So my suggestion is that for palliative radiotherapy, the chest wall to check the skin, chest wall metastasis, and then you go for brain radiotherapy for brain. And after testing, if we get the result, accordingly we will move forward for the treatment purpose. So my final suggestion, she may need chemotherapy, it is as palliative purpose. This is my suggestion. Thank you all.
I have one question to Professor Benpat, sir. Sir, in this heterogeneity, when we think that which one is taking upper hand, like TNBC, or as you say that brain mets is more likely with the HER2 positive case, and you also suggest like this. So when we treat a patient and when we see the progression with the things, and when the patient has a heterogeneity, so what should be the best option of treatment with this heterogenic tumor? Should we continue the anti-HER2 therapy along with the chemotherapy? Is that you think, or am I right what I am thinking?
Yeah, I don't think there's a right or wrong here, and that's why I think getting the chest wall may actually help kind of determine as a surrogate marker what might be going on in the brain in terms of the therapies. You know, in the absence of really knowing, I think just doing what we know with the information we have and what's available would probably be the most logical course. Meaning, for example, that if we have the chest wall and we biopsy and it's still HER2 positive, then we could try to get HER2-directed therapies with the drug in HER2, but still carefully monitoring the brain to seeing if there's any recurrence despite having that therapy. Now, again, antibody-based therapies aren't thought to cross and traverse the blood-brain barrier that effectively, but there is some evidence that for established metastasis, at least, that the leaky vasculature that antibodies can get through. There is some data with TDM1 as an example for that. I think in the absence of knowing, though, trying to get something that would actually afford best benefit, and that's why I mentioned if it's available to get the Enhertu, because there is that data that will also work in so-called HER2 negative disease, but as long as it's expressing some HER2 positivity, you might actually be able to get both populations of cancer cells, both the HER2 positive and the HER2 negative. The same may also be true with sacituzumab, because as I was mentioning earlier, TROP2 expression seems to be pretty ubiquitous on many cancer cells of epithelial origin. So those are two of the kind of drugs that I would try to put up or try to get and use first, depending on her HER2 status of the recurrent biopsy on the chest wall. I think because she's had whole brain radiation already, my hope would be that will at least control the disease for some time. But depending on what she's on and how she responds, and if she recurs, let's say if she recurred on triple negative based therapy, then if you can get tucatinib, that might be something that I would try as well. Tucatinib is not also the easiest drug to take because of the diarrhea, and it's usually given with capecitabine and then systemically with trastuzumab. But I've seen patients respond who don't necessarily have to get all of the systemic components of that, meaning just the tucatinib. But I think that right now, you know, I'll be honest, I think this is a very difficult case. And I also did want to mention, I agree with repeating with the PD-L1, that is something that might also change. So that could be an option for her if that's PD-1 positive now. And then also someone else had mentioned that if we go way back, I think most of us would have probably treated this neoadjuvantly now, because there is data to suggest that they don't, this patient had not achieved the pathologic complete response, then switching to Kadcyla for the remainder of the year would have afforded some benefit.
I have one question to you. Is this liquid biopsy giving us any information or any benefit?
Yeah, it's not in the sense that
Is it helping us in any way now?
No, I would say not, other than that if you have these markers, if it's available to get a second liquid biopsy after some therapy, you could use this to try to track the mutations and see what happens when you do it. Now, this is not something that we know is approved yet in this country. Myself and many others are working on this from a research aspect where using the quantitative aspects of the tumor mutations that you see may tell us sooner than a CAT scan whether or not the patient's responding. But that has not been definitively proven to be helpful or even possible yet. As I said, there's many trials that seem to suggest this retroactively, but none that I'm aware of that have really definitively proven clinical utility in a prospective fashion. And I do also just want to mention that one cannot repeat these or use these as a surrogate germline test, but since she did get definitive BRCA1 and 2 testing, then I do think that that's a true negative. And then all these other things, again, on a liquid biopsy, you cannot say that the blood tumor mutation burden, the microsatellite status, and the tumor fraction, that's not something that on a liquid biopsy is reliable when it's negative. Only when it's positive can you have some faith that this is probably real. Depending on the number of what we call sequencing reads on that TP53 mutation versus the HRAS, one could suggest that the TP53 may be the, if you will, the driver or the parental mutation that drove this patient's cancer because the fraction is higher than the HRAS.
There is a question in the chat box, like role of HER2 TKI regarding tucatinib in this particular case. Any of the panel member would like to take this question?
Yeah, that's the drug I'd also mentioned. I think for right now, without knowing that she actually has HER2 positive disease in her brain, I'm not sure I would use that. Again, I think if she gets, let's say, triple negative based systemic therapy and then still recurs, because obviously getting a brain biopsy is not going to be the easiest thing. I might then try to invoke the use of tucatinib, but I'm not sure that using that right now in the absence of knowing whether or not she actually has HER2 positive brain mets, when we potentially could save this for later. She's gotten whole brain irradiation. Tucatinib still has diarrhea, even though it's supposed to be more selective for HER2 as a side effect. And it's supposed to be given with capecitabine, which I was mentioning earlier can worsen that side effect. I have seen people drop or lower the dose of capecitabine and still have some efficacy in terms of treating brain mets. So it's an option. I'm not sure I would invoke it right now.
Thank you, sir.
I also don't know because we barely use lapatinib these days. And if I recall correctly, she had already received lapatinib and capecitabine. So, lapatinib in its early days showed some promise of blood-brain penetration and controlling CNS mets, although it's never definitively proven. So I don't know whether or not that's actually going to lessen the likelihood of response to tucatinib.